Well, good morning, everyone, and a very warm welcome to our session on developments in abortion care. We're going to use the session to reflect and to discuss future directions in abortion care in Scotland. Just to set the scene for those of you that are maybe less familiar with abortion care, last year in Scotland, almost 14,000 people underwent abortion. So it is actually the most common gynecological procedure in our country. We know that people who live with deprivation carry much of the burden of abortion. Abortion rates in the most deprived people are over 2 times higher than those who are lesser deprived. And although abortion is very common, it's still a procedure that attracts controversy. People who are undergoing abortion may feel affected by stigma, by shame, and by secrecy. COVID has brought its challenges in many parts of our lives, and it has also brought challenges in how we deliver abortion care during a pandemic to such a large number of people. I'm hoping this morning we might hear some of the positives that have come from that. So to address these various issues, I think we've got a very interesting panel. The structure for our session is that we've got 3 different sets of speakers who will speak to their topic. We would like you to put questions into the Q&A section, because once we're finished our formal presentations, we're then going to come back together as a panel for discussions, and we'd very much want to include you as the audience in our discussions. So please, whilst you're listening, any questions, pop them into the Q&A and we'll hope to come to them later. So our panel, I'm sure they will all introduce themselves, but we have Carrie Purcell, who is a principal investigator in the Sexuality and Abortion Stigma study. We also have a team from Edinburgh who are going to report on telemedicine abortion care in NHS Lothian. And we have Rachel Wilson-Lowe, who's a researcher who's going to speak around abortion support and information online. Again, I just want to cover before we open our discussions that our panel is very much minded that abortion services in Scotland are for anyone who needs an abortion. People who need an abortion cover a wide spectrum of people. They may be cis women, they may be trans men, they may be non-binary people. We will often use the term patients in our discussion, and we entirely intend that to be an inclusive term. It encompasses everyone who needs our services. Some studies have only included cis women, not for any intention to exclude anyone, but because the people who came forward to participate in the study were cis women. So I just wanted to be very clear that Scottish abortion services are inclusive for everyone. So I'll hand over to Carrie Purcell, who's going to set the scene and start our discussions for this morning.
Thanks, Audrey, for the introduction. Good morning, everyone. I'm just going to share my slides now. Bear with me a moment. Okay, there we are. Right. I hope you can all see those slides now. So, yeah, what I wanted to do this morning, really, I know Audrey did introduce me. I'm a research fellow at the Social and Public Health Sciences unit at the University of Glasgow, and for the last few years I've been working on the SAS study, the Sexuality and Abortion Stigma study, which I'm going to say a little bit more about this morning. What I'd really like to do this morning is set out some broad brush issues around abortion in Scotland, as well as briefly some research findings which speak to those. We've got some really interesting talks to follow on some quite specific issues in abortion research. So before we get to those, I'd like to look at some of the issues that have come up in the SAS study and to maybe set you thinking about how those questions might have relevance across the other projects that you're going to hear about today as well. So in terms of what recent research has looked at in Scotland, the Sexuality and Abortion Stigma Study, or SAS, has explored abortion stigma and normalisation. I'll say more about that in a moment. There have been 2 studies of early medical abortion at home, one which was UK-wide relating to COVID, which Lesley Hoggart was due to speak on today. Unfortunately, she now can't join us. But yeah, there's some really interesting research with sort of findings to be published fairly soon there. And then the other that you'll hear about today on early medical abortion at home, more generally, from John and Nicola. And then we also have Rachel's research, which has examined experiences of seeking support online around abortion. So each of these addresses different aspects of provision, practice, service gaps, and the wider context of abortion in Scotland at present. And they speak to some of those issues noted by Sally, Daniela and Ingrid in the opening session this morning about the impacts of changes brought about by COVID and the implications of those going forward. So what I'd like to set up is consideration of what the bigger picture might be, so that we can then hopefully come back in the discussion later on. To do that, I'm going to draw on some of just the high level findings from the SAS study. So SAS was a Wellcome funded study which ran from February 2018 to September this year. We used a qualitative secondary analysis methodology to re-examine existing qualitative data sets relating to abortion from Scotland, Northern Ireland and England. I won't go into lots of detail on the approach itself, but in brief, the idea behind qualitative secondary analysis is that it aims to balance the breadth of a large data set with the depth and detail of qualitative analysis. So the data sets that we were working with included interviews and focus groups with women who had sought abortion, with health professionals involved in provision. We had over 400 individual participants. So in qualitative terms, a really huge data set, and this was very much an exploratory study to see what further use could be made of these data, which were sometimes quite challenging to actually produce. In terms of concepts with the SAS study, we were starting from the position that abortion is stigmatised, but where other studies have often tended to focus on the effects of that stigma on individuals, what we wanted to examine was exactly how abortion stigma is constituted at a level of shared understanding. So I suppose we're basically, I don't want to go sort of full sociology here, but we're basically taking a kind of constructionist perspective, in that we all constitute and perpetuate our lived reality through shared symbols and meaning, and the mainstay of which is language. So we really focus down in detail on the language used around abortion in those data sets. This then led us on to consider, well, actually, how might we think not only about how abortion is stigmatised, but turning that on its head, how might it be normalised? So we focused on if and how the non-negative language, so both positive language and neutral language, used by those with first-hand experience of abortion might form the building blocks of a normalising narrative. We also looked at what some of the constraints appeared to be around using non-negative language, and ultimately we were thinking about how the dominant narrative of abortion as negative might be disrupted to affect broader change. And our aim was that this would be firmly grounded in accounts of those with lived experience of abortion. So when I was putting this paper together, I was trying to sketch out how you might visualize this relationship. What I've come to here is by no means perfect. It kind of occurred to me yesterday as well, maybe it looks like some kind of diagram relating to conception in some way, which was subconscious, maybe a kind of inadvertent thing there. But basically what I'm trying to illustrate here is that you have norms of female sexuality. So on the left-hand side here, so the norm that certain forms of behaviour are considered appropriate, others less so. And then also that women should be or should want to be mothers. So these norms arguably constitute and perpetuate what it means to be a woman, very broadly speaking, and deviation from that would be subject to social sanction via, amongst other things, stigma. Out of those norms, if you have a pregnancy which the pregnant person might not feel able to or want to continue, you see the emergence then of abortion stigma, because abortion conflicts with those norms. And stigma is the process of exercising power and marking out that which doesn't fit with a dominant norm, so othering it and framing it negatively. Then within abortion stigma, on the right-hand side, as some of its component parts, you have, if you like, what I'm framing today as abortion norms. So the shared understandings of what abortion is or signifies, and effectively the means by which stigma in this context functions. So two of the key abortion norms that we've identified in the analysis of the SAS data were, one, that abortion should be concealed, kept quiet or silenced, and two, that abortion is by default traumatic, negative, or sad. These are just two examples. I could talk about more norms, but I want to briefly look at these two in slightly more depth, because the significance of these norms is that they contribute to determining how abortion is experienced. So thinking about this norm one, first of all, so abortion is something to be concealed. Slide. Concealed or silenced. So there was broad recognition in the data that we subjected to secondary analysis that abortion is not spoken about. And this was commonly linked to language relating to shame. Many women who had undergone abortion were not aware of knowing anyone else who had. Many had talked to very few people about their experience, some to no one at all, other than the researcher in some cases, despite that fairly persistent figure that around 1 in 3 women in Scotland and elsewhere will have an abortion at some point in their lifetime. So there was also a clear sense from the data that silence perpetuates individual difficulty for those undergoing abortion. And I think the quote on the slide here really, I think, encapsulates both these issues. So this woman's talking about it's not spoken about, people don't talk about it openly, and that's why you feel more ashamed of doing it, because you don't sit down and have a conversation about it. So that actually makes it a harder thing to do. And this tendency towards silence, it also appeared in some of the provider data, the health professional data that we looked at as well, where health professionals described a tendency to not talk about or to downplay their work in abortion care. What we were interested in, as I've noted, was where and how challenges to these norms could be seen. And I think this was possibly more evident in the health professional data. You could perhaps argue that they might be speaking from a relatively more powerful position in terms of being able to challenge those norms, in their position as health professionals. But some women who had sought abortion did also say that they had, and that they would happily talk to anyone about their abortion. But they were very much in the minority. And what was notable to me was a real repeated refrain across a lot of the data, again, of I didn't want to tell anyone. It was just, a really common way of framing their experience. Although we didn't always have the option from the data, because it was secondary analysis, to kind of probe into that in more detail. So one of the downsides of doing secondary analysis, I think we could suggest that this was indicative of the powerful norm of silence around abortion and the constraining effect of abortion stigma. So yeah, I'm conscious I'm digressing slightly, and I'm probably running out of time, but what I'm getting at really is that, for one, the silence around abortion is a self-perpetuating norm. Silence begets silence, but also that it's an incredibly difficult one to shift. There are a lot of activities and organisations that aim to address this, some of which some of us in the panel are involved in, like the Abortion Talk charity, which is really important work, because it's really something that needs not just individual level action. Supporting individuals to talk about their abortion in the way that they want to is important, of course, but it takes more than individuals trying to take on that stigma and silence on the front line to affect change. What's needed is a real sea change that shifts the power balance to mean that talking about having purposefully ended a pregnancy doesn't put somebody in a vulnerable or a position of reduced power. Obviously, we're talking about some fairly fundamental patriarchal structures here, so piece of cake to address. But I'm hoping something that we can get into in the discussion a bit more. But to just quickly move on to norm 2, abortion is by default traumatic, negative, or sad. There's so much, again, that we could get into here in relation to how this was talked about in the data set that we looked at. It certainly was the case for some people that it was experienced in this way. it was striking to me how much of that related to anticipated negativity from others and expectations that abortion would or should be an extremely physically and emotionally difficult experience, which I think highlights the impact of dominant narratives around abortion and how women draw on these to frame and interpret their experiences. Again, sort of conscious that I'm probably going to run out of time. So what I'm going to focus on is that although the vast majority of language that we looked at was negative, there was overt, explicitly positive language used to describe experiences of abortion in a small number of cases. So here in the just a couple of examples here, you can see women talking about it being actually quite a good experience and it being something that made them happy. And we've gone into this analysis much more in the papers that we've published, so I can direct you to those if that is something of interest. But what I want to leave you with, as we move into the rest of this morning's papers, is just the idea that current norms in how it's acceptable to talk about abortion shape how it's experienced. Those norms that we're kind of working with at the moment as things stand are the building blocks of abortion stigma, and they are closely related to norms of femininity and what it means to be a woman in our society. Dominance of stigmatizing framings of abortion can be challenged. It can be addressed by changing the language that we use, and I expect that, probably most, if not everyone in the audience today is acutely aware of the significance of our language choices in the work that we do. But the root causes of abortion stigma and the power relationship that it signifies really need to be recognised and addressed at a structural level, including from within the healthcare system specifically, as well as more broadly. So I guess there's lots of questions that I hope we can discuss about how we continue to move forward in that respect. So I just want to close then with a very quick thanks to the SAS team. So Karen Maxwell, our research assistant who did much of the analysis on the project, co-investigators Fiona Bloomer, Lesley Hoggart, Sam Rowlands, our funder, Wellcome Trust, and the original research teams who very generously shared their data. As I say, we've published 2 papers so far and a couple of short briefing papers as well, which are all available from the project website, which is sasproject.org.uk. Do please have a look. And I'd like to hand over now to John Reynolds-Wright and Nicola Boydell, who have a video on their study of early medical abortion at home in Scotland. So thank you. There we are.
To share our findings on women's and health professionals' perspectives on telemedicine provision of medical abortion during COVID-19. I am John Reynolds-Wright, and I am joined today by Nicola Boydell, and we are part of a multidisciplinary research team at the University of Edinburgh. I will begin by providing some background on the Choices Clinic, the NHS abortion service in Lothian, and how we moved from an in-person model of care to the telemedicine pathway and the evaluation of this that we conducted. Nicola will then present our data on qualitative interviews with patients and abortion providers during the first few months of the telemedicine pathway. The Choices Clinic is a community-based NHS abortion clinic within the Lothian Integrated Sexual and Reproductive Health Service based at the Chalmers Centre in Edinburgh. Choices has a track record in service development and improvement with a focus on innovation in medical abortion and patient-centred care. Prior to the COVID-19 pandemic, patients choosing an early medical abortion at home made a single clinic visit for assessment and treatment. Mifepristone was administered in the clinic and misoprostol was taken away to be self-administered at home. When COVID-19 restrictions were put in place in March 2020, changes to legislation meant that both medications could be administered at home, and clinical guidance emphasised the use of teleconsultation to prevent the risk of COVID transmission. The Choices service rapidly pivoted so that all patients received telephone consultations. Routine ultrasound scanning was eliminated from the care pathway, and clinicians who had not previously worked in Choices but were part of the broader sexual health service joined the team during this time when other clinical activities were halted. Here is the patient journey through the telemedicine medical abortion at home pathway at the Choices Clinic. The person seeking an abortion calls the booking line for an appointment, and an appointment is arranged within 48 hours and sometimes the same day. If ultrasound is required, then this is booked for an in-person clinic appointment. Medications are then either collected from the clinic collection point or they're couriered to the patient's home address. The abortion treatment is then administered at home. 2 weeks later, the patient performs a low sensitivity pregnancy test and calls for support if it is positive or they are having concerning symptoms. If the test is negative, the abortion is complete. Overall, the aim was to evaluate the effectiveness, safety and acceptability of the telemedicine pathway in the first 3 months of this new service. We conducted a prospective observational cohort study and used data that was routinely collected by the abortion service, along with researcher-administered questionnaires and a review of the electronic patient records at 6 weeks after treatment. As part of the evaluation, we conducted an embedded qualitative study to explore the views and experiences of women using the service and staff providing the service in rich detail, and these are the data we present today. Within the qualitative evaluation, we wanted to know about the patient experience of seeking abortion via telemedicine, how acceptable this was, and how COVID-19 had impacted their experience of care. From the provider perspective, we wanted to know about their views on the rapid move to telemedicine provision of the service and the elimination of routine pre-abortion ultrasound scanning. We recruited 20 women who had accessed the telemedicine service and had an early medical abortion at home. The demographics of these women are displayed and are broadly reflective of the wider patient population accessing care at the Choices Clinic. We recruited 16 abortion care providers, a mixture of nursing, midwifery and medical staff, representing the majority of staff working in the abortion service at the time. Junior nurses and new doctors are those who may have been experienced in their practice otherwise but were relatively new to the abortion service or had only joined the abortion service during this period.
Hello, I'm Nicola Boydell. Following on from John, I'm going to share some findings from our analysis of data collected as part of the embedded qualitative study. Given that we only have a short time, we're going to focus on the 3 thematic areas outlined on this slide that were discussed by both women and abortion care providers. Thinking then about our first thematic area. All of the women interviewed described their experience of the telephone consultation positively in relation to communication around the abortion treatment, as well as building rapport and gaining emotional support from abortion care providers. Women valued the clear, step-by-step approach providers took in explaining the process, and they emphasised that lots of time was given to them to ask questions. Women also noted that providers sought to build rapport and the way that they paid particular attention to their emotional state. As one explained, "I felt like it was really easy to talk to them on the phone. They were really understanding, and when I said that I'd been emotional, they took time to talk about that. I didn't feel like it was impersonal and just a list of questions. I felt like I had time to talk it through, which was really nice." Women also highlighted the benefits of the consultation taking place at home, a familiar space where many felt much more comfortable and at ease. Some described being able to write notes without concerns about being observed, while others talked about sitting in bed with coffee, able to wear pyjamas or other comfy clothes. The ability to choose the location for the consultation contributed to feelings of comfort and control over the process, and enabled some to feel more open to raise questions or issues that they imagined might have been more difficult if they'd been in person. As one woman explained, "I feel like if she'd asked me questions or if I'd had any concerns, I would have probably been able to say them in person, but because I was in my own space, I felt more comfortable and more willing to ask questions." Similar benefits around telephone consultations were described by abortion providers, particularly around women being relaxed and comfortable in their own home spaces. Providers reported intensifying efforts to ensure that patients had a clear and thorough understanding of their abortion treatment, and suggested that being at home enhanced this because it often meant that women were more relaxed and able to take notes during the consultation. As one doctor explained, the patient is so much more relaxed when they're at home, so they may be listening, they may be writing it down. I've never seen a patient write anything down in clinic ever, but I'd say 5 patients so far have said, oh yes, I'm just taking notes, so they're writing it down as you go. My feeling is that patients will come out of it with possibly as much, if not more, knowledge of what we've been talking about. The issue of visibility emerged in different ways within interviews with women and providers. Some abortion care providers expressed concerns around the lack of visual cues during telemedicine consultations, linking this to safeguarding issues such as detecting evidence of coercive control and domestic violence. Providers suggested that non-verbal cues as part of in-person appointments enabled them to make a more holistic assessment, enhancing their ability to identify safeguarding issues, and contrasted this with telephone consultations. As one nurse said, you can ask them, you can see them on their own, so you know that they're alone and you can ask them directly. I mean, do you ask them on the phone, are you safe at home? But I suspect if they've got someone with them who's abusing them, for example, are they going to say yes, they're safe? Whereas if they're on their own face-to-face, they might feel more able to be honest. However, as the service became more established, providers reported becoming more confident in their ability to detect subtle changes in tone, language and manner during consultations, enabling them to further question around safeguarding issues. Providers also acknowledged that the ability to detect domestic violence during in-person consultations wasn't perfect, and that tools such as the clinic safe word, which women could use to indicate that they were not able to speak freely, constituted an important safeguarding component of the telemedicine service design. Some providers suggested that telephone consultations could potentially improve the safety of women who were experiencing domestic violence, as the greater privacy offered by telephone consultations meant that there was less risk of disclosure. As one nurse said, I think because you're on the phone, I think that women are more likely to tell you than coming in here face to face, because they might say, well, if I open up that can of worms in the hospital, who else are they going to bring in to see me? What's going to happen? Is it going to escalate or whatever? The issue of privacy and visibility also came through in women's accounts. Telephone consultations were described as alleviating some concerns about visibility and about being judged by others, as well as breaches of anonymity and confidentiality. For some, visibility was explicitly linked to fear of judgment and abortion stigma, which women described the consultation by telephone as going some way to address. As one woman said, it's much more comfortable, and just in terms of confidentiality, it's a bit more, I don't know, I use the word secret. You don't have to be seen to be potentially going into a clinic that you don't want people to. You might not want someone to see you doing that. So I think it's quite a good thing that it can be done over the telephone from the comfort of your own home. Nevertheless, some participants noted challenges in finding private space for the telephone consultation. Our findings suggest that for those who didn't want to disclose the abortion to members of their household, finding private space where they could not be overheard was especially important, something which COVID-19 lockdown conditions at times made more complicated. Turning now to findings around ultrasound scanning. We found that the move from routine to selective use of ultrasound was generally viewed positively by abortion care providers. The approach was supported by clear protocols that focused on history taking and symptoms, and some staff suggested that this has the potential to enhance clinical acumen and judgment. However, early in this transition to the new telemedicine pathway, providers did acknowledge that they had experienced anxieties about the potential for both ectopic pregnancies or those at later gestations to be missed. These concerns shifted as telemedicine provision became more established, and also as provider confidence grew in both clinical protocols that minimised risks, as well as the pathways that were established to enable them to seek advice and to get support from senior nursing and medical staff. As one nurse said, "I suppose now that I've done enough, I've had a few examples. So I've had someone who wasn't sure of their dates and I've just arranged for them to come in for a scan. I've had someone who had pain and bleeding and arranged for her to come in for a scan. And I guess I've just sort of realised that we do actually ask the right questions and I felt more confident." Despite these initial anxieties around the shift in practice, providers could see real benefits for women. Ultrasound was widely recognised by providers as emotionally challenging for women seeking abortion, often because it's associated with continuing pregnancies and can also act as a reminder of previous desired pregnancies for those who have experienced pregnancy before. As one nurse said, "I think the ultrasound scan can be a trigger for some women in terms of evoking emotion and sort of guilt and doubt. Even women that go on as they do, most women still, to have the termination after the scan, I think it's a touch point for emotion for some women." And this aligned with women's accounts of ultrasound scanning. A few women reported having received a scan either because they were unsure of the date of their last menstrual period or because they'd already accessed the early pregnancy unit due to suspected ectopic pregnancy. But of those who had not received a scan, most described being comfortable with and actually a preference for not having a scan. And in line with provider accounts, we found that ultrasound scanning was really welcomed by those who associated scans with positive experiences of desired pregnancy and those that were anxious about the prospect of being required to undergo this as part of the abortion consultation. So as one woman said, "Getting a scan, it kind of makes it real. When you think of getting a scan, you just automatically think of a baby and pregnancy and things like that in a happy time. I think the scan could make it quite emotional. That's just my opinion." So what can we take from the findings of this study? Well, the headline is that both women and abortion care providers value the provision of telemedicine abortion care and believe that it should remain beyond the COVID-19 pandemic. We found that women's experiences of the telephone consultations were positive, and this helps support the quantitative findings around acceptability as part of the wider service evaluation. Aligning with other research around early medical abortion at home, we also found that the telemedicine service extends some women's experiences of the comfort and privacy of being at home. However, we think it's important to point out that we can't assume that the home is a private, safe or comfortable space for all women in which to undergo an abortion. And for us, this highlights the value of offering a choice of telephone and in-person consultations wherever that's possible. We found that women were confident and actually often preferred to proceed with the abortion without an ultrasound scan. And for some, the elimination of routine scanning helped to reduce their anxiety about the abortion process. And although abortion care providers described some initial concerns around the transition to selective use of ultrasound, as well as in identifying safeguarding issues during telephone consultations, over time, the support and clinical protocols put in place helped increase their confidence as part of service delivery. So taken together, the findings of this evaluation lend further weight to the research evidence that supports the continuation of telemedicine abortion services. And we hope that this service will continue to be provided in the future and that the studies that we've published will help to support that decision. If you'd like to read more about the work which we presented today, our papers are available open access. Thanks so much for listening. We're really happy to take any questions during the panel discussion.
Hi, my name is Rachel Wilson-Lowe, and I'm a PhD student at the University of Glasgow. And today I'll be talking about some of my thesis findings, in particular how and why women used online resources to find social support in relation to their abortion. So a little presentation outline. I'll talk about, kind of introduce my study, then give some background on social support and online resource literature, then talk about current abortion-related spaces that exist online and reasons why participants sought out abortion-related support online. And then talk about just the types of support that were described by participants and specific online activities that were used to engage with and receive social support online, and then conclude. So a little background into my research. During the course of my master's research, I found that some women chose to share their abortion online, seeing these virtual platforms as appealing in comparison and in conjunction with in-person communication. I looked into these behaviors more and found a gap in the literature as to how and why women use online spaces to share and read personal abortion narratives. This study sought to address these gaps and so explored experiences and motivations for using online spaces in relation to their abortion for 23 women living in Scotland. These interviews were conducted remotely with both individuals who shared their own experience and those who didn't contribute content but just read existing posts. And one of the primary reasons for accessing these spaces that was reported by participants was to find social support. Social support is a construct that conceptualizes how social interactions and exchanges with other individuals can help in coping with stressful life events and negative emotional states. And it's associated with better health and well-being more broadly, but also has been demonstrated to be linked to a more positive abortion experience. The types of emotional or social support are emotional support, which relays feelings of love and self-acceptance, and it includes kind of behaviors such as listening and giving somebody hugs and empathizing with them. There's cognitive support, which provides somebody with information or advice, so it's kind of problem solving and directing somebody towards a particular resource. And then there's material support, which is the kind of practical aid side, so provision of resources, giving somebody money, driving them to a hospital appointment, that sort of thing. And material support, whilst an important subcategory of support, isn't readily available online given the virtual context and wasn't described by participants in this study. So as such, it won't really be discussed in further detail. So why do people go online to access social support? Previous literature identifies several reasons why online spaces are appealing. There's low barriers to access, meaning that online spaces can be accessed at any time from anywhere with little to no cost. And also there's the ability to control privacy online and remain anonymous should an individual wish to. And anonymity kind of is discussed further in this presentation in relation to anonymous browsing behaviors. So what online spaces are readily available for women to talk and read through abortion online? Well, through my interviews and as part of an exploratory content analysis of abortion online, I identified a wide range of online spaces in which abortion is discussed. So there's some official organizations and healthcare websites such as the NHS and abortifacient pill websites such as Women on Web that provide healthcare knowledge and abortion access. There's also a variety of forums and discussion boards in which abortion is discussed, such as Reddit or Quora. And there's also personal social media platforms, which are a space in which abortion may be discussed on their own profile or in closed private groups. These spaces obviously differ in terms of purpose, but also in terms of anonymity and functionality. So why do women go online for social support regarding abortion? Some women in the study reported that they were embarrassed to talk about their abortion with others and kind of referenced feelings of internalized stigma. So Fiona said, "I was certainly embarrassed by it. There's not many people that I've told about it, but yeah, I guess it just gave you that kind of support that you were looking for, but you couldn't really get it because that would mean you'd have to talk to somebody. And by reading it, you could just kind of go, yeah, it's hard to explain actually, I think. It's more, yeah, somebody else felt it. It wasn't just me. It's not just me." Also, women describe not knowing any similar others in their social network and kind of demonstrated the pervasive silence around abortion experience, limiting who women felt they could talk to. So Anastasia described, "I wanted to be prepared as, because I knew this is what I was going to be doing. And I think it's just a sensitive issue. You can't always talk to people. People don't openly announce always that they've had one. So you don't really know who you can talk to." Other women described they kind of received inadequate social support from their in-person network members and so turned online. So I asked Nicole why she used a private browsing window to go online. And she said, because I didn't want my partner to know what I had been looking at. I didn't want him to know that I was looking into this, because his response was always the same. It was always, anytime I brought it up, you know, you don't need to rehash this. We don't need to go through this again. You just need to put it to rest. You need to put it behind you. You need to stop thinking about it, put it out of your mind. And those were the kind of responses I got from him. And yeah, so it was easier to hide that from him than actually tell him the truth about what I'd been doing. Some women in the study found that they didn't have a clear picture of what the abortion procedure or recovery would be like, even after speaking to healthcare professionals. Sorry, my dog is in the video. By going online and reading others' abortion narratives, participants could get valuable firsthand knowledge of abortion. So Heather said, I wanted real people with real situations and experiences and their kind of input and advice, if you know what I mean, rather than the kind of, I suppose, the kind of, I don't know, the official kind of advice or information that they give you kind of. I always felt like you would get more real answers from people that had been through it. Participants described finding various information about the abortion procedure and the recovery period from others online. Margaret said, so it was just wee things like that, just so I knew. Talking about what to pack, they were like, it's going to be long and boring. Make sure you bring your laptop, a couple of snacks. It's going to be a full day in there. Just practical things like a change of clothes, wear something comfortable, you know, all that. Just things I certainly wouldn't have thought about if I hadn't read them, which was very helpful. And other participants who described feeling some emotional distress about their abortions found helpful suggestions about how to remember their pregnancy and process their feelings of loss. So they received things like planting a tree or journaling or filling a box with pregnancy mementos. Please go lie down. This kind of leads us into emotional support. One particular sentiment that came up often in these interviews was the sense of loneliness and isolation that some women felt regarding their abortion experience. Although abortion is a common gynecological procedure, it's still exceptionalized in public discourse. Online context presented a space to find similar others and alleviate some of these feelings. So Nora said, I felt very lonely. I think that was the other thing. I kind of feel like you're the only person in the world going through this. I never met anybody or never knowingly met anybody at this stage. It felt like something very unusual and something that didn't happen very often and something that you were unlikely to ever meet somebody else who have gone through that. And as it turns out, I've now met lots of women who've gone through it. But at that point, it felt very, very lonely. I just felt an incredible sense of relief when I logged on and read so many other stories that had so many similarities to my own. Finding these similar accounts could be especially beneficial to women whose abortions did not fit within kind of popular narrative accounts of abortion, i.e. it being an inherently distressing experience. For Heather, whose decision and experience of abortion was reported without obvious kind of emotional turmoil, accessing similar accounts normalized and validated her internal understanding of her abortion experience. She said, yeah, so I was kind of reassured in a lot of ways because there was other moms that felt the same or other women that had been through it. And they were very matter of fact about it. And I could really relate to those. But it also reassured me that I was not the only one out there, you know, it was like that it was just kind of very black and white, you know, and unemotional. So that was a relief. And it certainly helped me kind of, I suppose, put these kind of thoughts and things in their place. And I suppose find closure with that a little bit. That everything's okay. I'm normal. I'm not a psycho or whatever it is. So there are many ways in that online support can be sought or received in virtual spaces. Notably, my conceptualization of online support encompasses one-way activities in which user behavior doesn't elicit a response, but the online activity is still considered supportive or helpful. So, for example, the kind of two branches of one-way online activities I included in my study were anonymous browsing behaviors, which describes online activities in which users read others' content without adding their own or interacting with said content in a visible way. It's also termed lurking in human-computer interaction literature. And click speech. So it describes one-click kind of liking behaviors online. It differs across platforms. Facebook has a range of sentiments, whereas Twitter just has like one sentiment, like a like or a heart. And then there's two-way online activities. So these include kind of posts and comments. So it's a broadcast communication style, so it can be seen by multiple users at once. And it's a more public form of communication in which users can write and share a post, and others can respond underneath said content, all of which can be seen by multiple users. And private messaging, and it allows for dyadic communication. It's a more private form of communication enabled on some platforms such as Facebook Messenger or direct messages such as on Twitter. And the motivations to anonymously browse abortion-related content online varied. So some reported a desire to conceal their abortion from their network. I asked Nicole if she considered interacting with the posts that she read, and she said, no, I didn't want to. That would have required me to create profiles and go down that route of getting information sent to me and stuff like that, and I didn't want that. I just wanted to see what other people had done in my situation. But others reported that social support was perceived as already available without them having to interact. So Anastasia said, I actually had enough information. And thank goodness people are going on forums and going into a lot of detail, because you might have a question and then it gets answered without you even having to ask. And the reasons people described behaviors of click speech, it's a low-cost social behavior, and it requires minimal effort and allows a certain degree of ambiguity regarding intent. So Alice said, I feel comfortable publicly saying that abortion is something that I support and I care about. I wouldn't necessarily want to identify myself as someone who'd experienced it. So by liking abortion-related content, users like Alice could demonstrate support for abortion online without having to divulge their own experience. And it's also perceived by both the liker and the liked as social support, as Paula demonstrated. Paula said, I remember a lot of girls liked it. A lot of silent, well, not silent, but a lot of passive support, I guess, where they're not vocally saying I agree, but obviously the likers are. It's a form of social support. In terms of two-way online activity, private messaging was described by some participants. And this type of communication is more similar to texts or emails, given its dyadic nature. However, not all online spaces and platforms have this functionality, and it also narrows support to one user rather than a broader audience. So, for example, one participant, Rebecca, chose to reach out privately to another user who was experiencing online harassment. Thereby, she limited the possibility of experiencing her own stigmatizing interactions for supporting her, but nobody else could benefit from reading it through anonymous browsing behaviors. But also, private messaging was seen as inappropriate or invading a user's privacy if it was unsolicited and you didn't know one another offline. Posting and commenting enabled participants to communicate with a wide audience. It allowed users to ask specific questions and to resist abortion stigma through publicly sharing their abortion experience. However, because this abortion-related content could be seen by multiple users, the potential for stigma and online harassment was significantly higher. So, for example, one participant, Hannah, asked for advice about her abortion in a private Facebook group for Scottish women, and she received upwards of 50 negative comments and only 3 supportive comments. So online support reduces barriers of access in terms of time and money that has to be spent. It also can be gained anonymously for some participants if they choose to, but also provides a space for individuals to resist and reject abortion stigma because they can share their abortion narrative publicly if they so choose. But online spaces are also inundated with abortion stigma, as reported by participants in this study. So does online support for abortions contribute or combat abortion stigma? In that people who have abortions can remain invisible, but also simultaneously increases the visibility and opportunity to resist and reject stigma for those who choose? I suppose the short answer is both, but it does provide more choice and options for social support for women, especially those who have some form of internalized abortion stigma and those who have unmet support needs from in-person interactions. So online spaces can be valuable sources of social support, but also things need to be considered, such as how one might respond or feel about online stigma or harassment, and whether or not somebody wants to remain anonymous or post with identity linked accounts. So, any questions? And my contact details are on the bottom of the screen, and sorry for my dog being in the presentation.
Thanks, Rachel, and thanks, Nicola and John. I just wanted to come back in with another kind of couple of comments to sum up before I hand back over to Audrey, who's going to chair the discussion for us. I guess just so, bear with me, I have another last slide just to pop up here. So yeah, so some really fascinating talks and presentations on some very recent primary research there. What I wanted to come back to was the question, I guess, of normalization and the idea of reimagining services that came up in the introductory session this morning. Since I know I certainly don't have all the answers, so to ask our audience, hopefully, before for their input to consider really what it is that we are or should be talking about normalizing. Again, just to know as well, I know quite a few people have joined us sort of into the session as well when we're talking about people who are seeking or have undergone abortion. We're using terms patients and women. These reflect how the participants in our studies have identified, but we are very much speaking to inclusive view of abortion care. But are we aiming to normalise then, I guess, just in terms of some questions or some provocations for the discussion, are we aiming to normalise positive talk about abortion? So, you know, for example, it is normal to talk about abortion as a good thing, as a routine, unexceptional option for someone who is pregnant and doesn't want to be or doesn't feel that they can be. But, you know, also to talk about it, recognise it as something that can be difficult or challenging personal experience if that applies. Are we aiming to normalise self-managed abortion? So, you know, i.e. it is normal to be able to end a pregnancy with medication at home, if that's what the pregnant person wants to do. And I guess this raises questions of, you know, what does this mean for the visibility of abortion as a healthcare service if it's something that happens in the home in the vast majority of cases? What does it mean at a political level? What about alternative methods of provision? Are we aiming to normalise abortion as healthcare? You know, so it is normal for abortion in all its forms, early medical at home, later abortion, abortion for fetal anomaly, to be provided as routine, unexceptional components of sexual and reproductive healthcare. And if so, what change is needed to make that you know, truly a reality? And are we aiming to normalise women's bodily autonomy? So, you know, who'd have thought 2021 that we would still, that this still wouldn't be a given? But this is where the stigma as a power relationship comes in. So, you know, is the norm that we're aiming for here, that it is normal for women to have full control of their reproductive bodies without judgment or control from elsewhere. So I guess, yeah, that was just my kind of thoughts based on the talks from everyone this morning. Hoping that we'll have some discussion. I am going to hand over to Audrey now, our fantastic chair, and let her say a few closing comments. But thanks very much, everyone.
Okay, thanks, Carrie, and thanks so much to all our speakers this morning. I think even although I've existed in abortion care circles for a long time, I think we do always learn something, don't we? And I think just thinking about what Carrie was saying, I was then I was going to open a discussion around do staff reinforce stigma, but then I was just reflecting on how I had opened the session, and I think to my own shame, I think I said something along the lines of people living with the most deprivation carried the greater burden of abortion. And again, I suppose that is again reinforcing abortion as a negative concept. And perhaps I should have said, isn't it fantastic that services are so accessible that people who are living with poverty and deprivation are able to access services in such numbers? So there's a flip side to everything. And thank you, Carrie, for making me think further about the language that we use. So our plan for the next half hour or so of the session is really to open to discussion. I think what I'll do first of all is perhaps open the discussion to the panel members who've spoken. If people have any questions or points they wish to make at this point. Meanwhile, we'd ask our audience if you have any questions for the panel, anything you want to discuss further, please pop that into the question and answers. I think there's maybe a couple of questions in that we'll come to. But yeah, we'd like to invite everyone to participate if they'd like to. So can I open up to the panel if anyone has any further reflections or comments they'd want to make at this stage while we're waiting on some questions? I've a couple of things that perhaps I could say myself. Could I ask the team from Edinburgh? I think you said a few times you referred to it as a telephone consultation. Now, a lot of NH services have obviously opened up to remote consultations, and a number of services are using Attend Anywhere or those types of platforms, which are video consultations. Do you think that's something that would be suitable for abortion care? Do you think it's something that might resolve some of the concerns around safeguarding, or do you think it's a no-no?
John, did you like to come in there?
John might be best placed to answer that question.
Both Nicola and I are nominating John.
So certainly within our data from the women that we had interviewed and the staff that we'd interviewed in our own local service, there was a kind of lack of desire to move towards towards a visual form of telemedicine, and kind of the reasoning behind that was a little bit behind that invisibility that being on the telephone affords you, and actually not having to have somebody looking at you and invading your space and seeing what's around you from the patient point of view. And also providers kind of acknowledged that and realized how much more invasive they would feel, how much more invading they would feel to be doing that. But also there was this component of acknowledging that it's still an artificial way of seeing somebody face to face, and actually how much more do you get from having a video consultation with a patient in terms of safeguarding. You can have somebody that's their abuser hiding behind the camera, for instance, or just outside the door, and then you've kind of lost that easier rapport of having somebody be invisible and be anonymous to you in a certain way. And you've not gained back all those things that you might get by having somebody sat in a clinic room in front of you, where you know that you've got them on their own, or you are able to have an in-person interpreter or whatever. There is evidence from England that's quite positive around that, and I know there's a paper recently published by the group from Mary Stokes International, who provide a lot of abortion care in England in the voluntary sector, and they use it, and they kind of did describe in their paper around this reticence to use it, which I suppose I'm sharing with you from as a provider and from our research experience. But actually, once people did use it, they were quite positive about it. So it's one of those things that I think is not a bad move if that's where we went towards, but there's also perhaps an element of not needing to reinvent the wheel when we've got something that works really well and serves the purpose that it serves, and people are so familiar with in terms of telephone calls. How much extra does having that video call add to us? I don't know if there's anything else that Nicola or Jeni wanted to add.
I was just going to say it also reminds us of the benefit or the advantage of doing qualitative research in this area as well, because I think had we guessed this, I think I might have thought that people would probably want video interviews, and there's almost like a scale of telephone being the least good, then video being better, and then face to face. So I think that we really need to continue to be doing these exploratory studies that are really trying to understand people's experiences, and that's the only way that we can really get the evidence base that we need to move forward in terms of improving or continuing to improve care.
And I think I would just add, going back to some of the findings that we presented, I think it was really striking the way in which the women who participated in our study talked about being able to be comfortable and not being observed. So things like wearing pajamas, having a cup of coffee, not, for example, having to tidy up, or they're having their home spaces observed in a particular way. So the kind of the front stage that we are presenting now, we have to do quite a lot of work to make that happen, and that pressure to be taken off via a telephone consultation rather than a video consultation, I think has some benefits, which were certainly articulated by the women in our study.
Yeah, I think our experience in Glasgow has probably been very, very similar to that. We went to telephone consultation rather than video consultation at the outset, and feedback that we've gathered from some of our participants again has been actually the phone worked for them. There was very few people that would have preferred video consultation. And I suppose we all know our own anxieties, even if it's a Zoom with your friends. As you say, you tidy up and make sure you're sitting somewhere decent before you put yourself in video. So I think people, it is a real invasion of privacy to be inside a patient's house if we don't need to be. Okay, so let's, I'll go to some of the questions that have come in. So we have a question from Susanna Hammersley asking, do you think that access to telemedical abortion during the pandemic has reduced trauma associated with abortion? So do we think that being able to have your telemedicine consultation and then carry out abortion in the home setting, will that lead to people feeling less distressed and traumatised by their abortion? And then do services who are providing abortion, do they make people aware of the online resources that are available? So maybe should we put that question, do you want to maybe come in on that, Rachel, about how do people know about the online resources?
Yeah, so it did kind of depend on the abortion experience and why they were seeking to terminate their pregnancy. So in my sample, we had a couple women who had diagnoses of fetal abnormality and were going down that pathway in terms of accessing their abortion, and they were directed towards online resources and that were primarily like charity-based resources. So the Antenatal Results and Choices charity has online resources and an online kind of discussion and forum in which they could go there for online support. Whereas the women who were accessing abortion for other reasons were not directed towards online spaces, or at least didn't report being directed towards these spaces by healthcare professionals. A couple did report being directed towards certain spaces by friends, like a closed Facebook group for women in the UK. One or two people went there because a friend had suggested it, but in reality, the vast majority of the participants had to search and find these spaces, and that kind of was associated with some difficulty, either because there's just so much on the internet. God knows you can find anybody or anything, but that also meant that they were being exposed, I suppose, to spaces or content that was anti-abortion. So that kind of was a problem. So I think being directed towards sources of support that healthcare providers kind of have been on and approve of, for instance, the subreddit r/abortion was a really positive space that women described, and I myself have been on there and done some content analysis. So I think it's difficult for healthcare providers, obviously, to direct patients towards these resources, given that they're kind of not vetted. But I think that would be helpful for a lot of women if there was spaces they could go on that weren't official healthcare spaces like the NHS website or BPAS that allowed for some sort of interaction or allowed for more experiential narrative posts that was contributed by users rather than formulated by the online space people. Hopefully that helps.
Yeah, thanks, Rachel. I certainly think we probably, and John might want to come in on this, certainly I don't think we direct people to online resources, partly because of that fear that if a space is unmoderated, someone could then go into a space which was very negative towards abortion. But realistically, we know when people are looking for support, for answers, etc., the first thing they do is often go online. The service in Edinburgh, do you direct people to any online resources?
We do, not about kind of support afterwards. So in terms of our kind of overall package of information, we have a couple of animations on our webpage, on our clinic webpage, that provides kind of basic information about medical abortion and what to expect in terms of the process, but also the actual process of how it feels to take the tablets and pass the pregnancy. And we also have got written information on that webpage as well. And within the pack, the physical package that people get, which has their medications in, there is printed information in there, and included in that is a way of accessing our own counselling, in-house counselling service if women or patients feel that they need to do that in the time after they've had their abortion. It is something that is not used very often, and again, it's very difficult to unpick that thing around trauma and stigma, but it is having an abortion an inherently traumatic thing. Is it only traumatic if people are experiencing stigma in the way that we stigmatize it in society? So the idea that everybody needs to have access to resources to help them recover from trauma following an abortion, I think probably is something that is not the case. I see that Leanne Hughes, who works at the Chalmers Centre for Healthy Respect and the young person strategy, has put in the comments bit rather than the Q&A about some new work that they're doing around kind of online chat functions with young people, and whether or not this would be something that would be valuable to people having in following an abortion, and perhaps it would be. Whether that's something that needs to be done like locally at individual levels, or whether that would perhaps work best as a pan-Scotland thing, I don't know.
Could I just come in there also in relation to the first part of Susanna's question that John's kind of touched on there? Do you think that access to telemedical abortions during the pandemic has reduced the trauma? I think overall, I think we would definitely say across the studies that we've done for many years now, is that one of the things that causes people most stress is worrying about access and being uncertain about how they will get access and whether they'll get access, whether they'll be allowed to have an abortion. So anything that we do that improves access and makes access easier, I think is inevitably going to have a positive impact on that type of stress. So I think in that sense, the telemedical abortion service was part of that whole process of making access a bit more straightforward. And again, I would come back to that idea of challenging that we can make those assumptions. Certainly from the research that we've done, the majority of people that we spoke to don't describe having an abortion as being traumatic. And that I'm not denying that there will be, for some women, it will be a deeply traumatic experience, but certainly from our research, that's not a commonplace way in which women or the participants describe it. And it was much more, in terms of the telemedicine, it was much more about enhancing convenience, enhancing comfort. And again, both of those things are positive aspects of this new type of delivery.
Sorry, go ahead.
I was just going to say that I think that's a very well made point. Certainly from work previously in our area, we were aware that one of the things that people coming for abortion found very difficult was having to repeatedly explain yourself and tell your story. So having to explain when you want to make the appointment, telling the person you come to see face to face, then perhaps seeing someone else for a scan, seeing someone else to do some swab tests, etc., and someone else to give you your medication, or someone else when you go to hospital. People feedback to us has been very positive, that actually speaking to one person in a timely manner, so being able to access your first consultation within a few days, as the Edinburgh group referred to, takes away some of that stress of waiting, and also that repeated storytelling. You can choose to share your story with only one person who does your telephone consultation if you wish. You don't have to repeatedly explain yourself to other people.
I think, yeah, if I can just jump in on, and just to kind of back up what Jeni was saying about the point about where a sort of sense of like difficulty or trauma might come from. I think in so many of the studies that we've looked at, and so some of the data we were looking at in the SAS study is some of the projects that myself and Jeni have worked on in the past, and other studies from Scotland, but just that idea of it is a kind of powerful expectation that people have, that their encounters with health professionals are going to be difficult, that the abortion itself is going to be difficult. I think for me, there's always a sense that for people seeking abortion, that it's the circumstances of the pregnancy itself that are the difficulty and the source of a lot of like difficult emotions. And then they come to a point where they're maybe surprised actually that the abortion itself has been something that's been relatively straightforward, but then they're left feeling at odds with, where's this thing that I'm supposed to feel really conflicted or torn up about or kind of devastated, and actually it was a very straightforward thing and I'm fine. Not to say that there's not other things going on in their life that are difficult round about that, but I guess that this sort of presupposition that that there is something kind of inherently traumatic to abortion is not something that has stood from any of the studies that we've done, really.
I think one of the nice things following on from that about online spaces was that there seemed to be a wide variety of kind of abortion narratives online in comparison to kind of what we see in media representations or in news. So women or patients who had both kind of positive experiences and were surprised by that could find others' experiences and feel, more normal or feel that was okay, as well as those who did feel some form of loss after their abortion, who maybe felt that they weren't allowed to feel that way because they made a decision that was expressed by some of my participants, got to see that there were others who felt that way as well, and kind of exchange little tips like I suggested about planting a tree or buying a necklace if they, to remember that pregnancy by. So it was nice to see people on a wide swath of abortion stories, and both of those people benefit from online spaces.
I guess that's something that's very difficult. I think, Rachel, you already alluded to this, something that's really difficult for formal healthcare services to provide is something that's going to speak to all that huge variation in experiences and needs, and something that's not about, more standardized information about this is what your experience is going to be like, because a lot of the studies, I guess, that we've done over the past, 10-ish years, we've had, participants telling us that they're really, the thing that they're missing is that more experiential information of like, what is this going to be like? What's it going to feel like? What's the whole kind of process going to be in a more kind of embodied way or in more of a kind of emotional sense? That, yeah, it's really hard to convey for health services in any sort of standardized way. So I don't know what an easy way is to address that, but it is certainly something that, going into a forum, I think there's probably parallels with other aspects of like pregnancy and different outcomes, different routes, that there may be information that you seek in something like an informal forum that it's very difficult to provide more formally.
Yeah, and I think part of that also comes down to the fact that a lot of our conversations about abortion are dichotomized in terms of being pro-abortion or anti-abortion. And that can be reflected in a lot of the narratives that we do get. So, there are, if you look at Twitter hashtag movements like shout your abortion, or you know me was another movement. They were kind of very more skewed towards positive representations of abortion and rejecting stigma in that way, which was great. But then those who didn't feel that way about their own experience, kind of could feel silenced by that. And then you get the kind of anti-abortion narratives of abortion is horrible and it's traumatizing, and it's this and it's that. So you're tending to get both sides of the spectrum in different spaces, but in the kind of more informal spaces and less politically motivated spaces, you're getting kind of that somewhere in the middle, which I think is really helpful. And I think we need to open more conversations that allow for nuance in how we're feeling, not just entirely positive or not just entirely negative. Yeah.
I do wonder as well about, just based on some of the things that you were saying, Rachel, in terms of how women had been looking for descriptions of experiential descriptions of things, and that kind of thing we know already about patients overvaluing anecdotal information and evidence over what they might see from an official source. I do think that in terms of going forward and designing patient information leaflets or patient information resources, I think we probably could incorporate that in terms of having testimonials, or, an actor just reading out testimonials from people who share them anonymously, that kind of thing, in terms of being able to perhaps standardize and quality check some of that more kind of personalized, individualized information for patients.
Yeah, I think that could be a really good idea. Although I did notice that in some of the transcripts and interviews with the women in the study, they did kind of recognize that the kind of testimonials as such on these more official spaces sometimes felt a bit formulaic. And so maybe having a range of those testimonies would probably solve that issue, as well as I kind of personally, not as a healthcare provider, but felt a little bit nervous sometimes when women would be talking about some of the stories they came across online that were like describing it as the process is quite horrific and really painful, and obviously it's going to be for some women who with a variety of pain thresholds. But then some participants felt really anxious because they read those and they're like, oh my God, it's going to be really scary and awful. Whereas not everybody felt that. So it's trying not to blindside people about, this procedure might be painful, but also not scaring them either. And I don't know how we could walk that line. Like, offer a problem, not a solution. So sorry.
I think it's slightly, I suppose, frustrating. Well, maybe frustrating is not quite the right word, but there are resources out there as well. Things like the My Body, My Life website, which has a huge array of stories, kind of first-hand accounts that have been, that have come from some of our research studies, or that have come from like direct contributions from the public through the exhibitions. But then it's, how do you actually get that out there, that resource is there? If for example, if clinics can't link directly to it, can't signpost to it, how do we kind of, you really publicize that those stories, which, are kind of, I suppose, still mediated in a way, and there is not an interactive platform so much that you can have a conversation with somebody, but there are certainly resources that can be looked at there. It's just, how do we get that out there?
Yeah, and I'm sure it's very powerful for people, whatever their experience has been, to be able to go onto some forum and see, actually, somebody said exactly what I've experienced. And I suppose that then does get us another step towards normalising it. Other people are having the same experiences that you're having. I mean, I certainly think the discussion's got me thinking around, how do we get some of this information over to the people that come through the service, that the patient information that they get, I suppose, is written by us and it's our perspective of what we think it's like when you undergo an abortion, and perhaps yeah, maybe it is time to bring some of that sort of lived experience into the information that people get, and to direct them to sources of information that we know is moderated and safe to some extent. Could I just bring in for the panel again a comment again from Leanne Hughes in Lothian, who said, acknowledging that abortion care is now, the animation is covered in relationships education, but it is a challenge getting an appropriate amount of time in schools to discuss abortion. And if it's something that children, young people aren't able to discuss in schools, is that the first step to the secrecy and the stigmatization of abortion care? Is there something that we can do that, if time is limited in schools, can we link young people into other online sources to get that information?
Well, I'm not sure. I mean, Carrie, I know there's the kind of Equally Safe at School program they're working on in our unit, as well as the STASH intervention that I helped work on, it was peer-led sexual health education, which was quite interesting, and having a lot of online resources to direct them to. I helped collate a lot of the memes and various kind of internet, I don't know what word doesn't make me sound old, like content that was shareable on these platforms. I think it was a closed Facebook group we ended up using. How can that also provided another space for individuals to talk about various aspects of sexual and relationship education out with the kind of school structure. So that might also be helpful, having those spaces for youths. But I agree, it needs to be kind of definitely more integrated into the education when you're talking about contraception or pregnancy. Also talking about, well, there's ways to end this pregnancy. But coming from the South, from the American South, myself, y'all's sexual health and relationship education is miles ahead of what I experienced. So I'm always quite heartened to hear what's on your list.
Yeah, I think something like, if more information and discussion around abortion could be included in that sort of peer-led approach that was used in STASH, I think that would be really helpful, because I think something that came up certainly in the young people study that I worked on with Jeni was that it continues to be framed, abortion continues to be framed as something, a kind of abstract idea for this kind of like moral debate in school that's taught in RE or those kinds of classes, rather than being framed as a healthcare issue. So again, it's a really fundamental question of what's the language that's been used, where is it being talked about? I know that is the really kind of embedded structural shift that you need to have to see any kind of change. As you say, from very early on. I think, as Leanne was saying in her question, is does it need to happen at a very early stage? And yeah, it does.
But then isn't that the same for like medical school education? Abortion is usually included in the kind of medical ethics section of class, rather than in the gynecological care. So even what doctors and healthcare professionals are being exposed to frames it in that sort of way. And I know we have some amazing healthcare professionals, both on the panel and audience members, who are doing their absolute best to normalize abortion care. But from what my participants said, there definitely was a range of experiences that weren't so great with healthcare professionals, from the GP to the actual abortion care itself. So we need to change how it's taught in medical school, as well as just to the wider public in education.
Yeah, I think I absolutely would strongly agree there, Rachel. Medical schools, their teaching of abortion has been very limited in the past, and you say it is often parcelled up with, ethical issues, contentious issues, etc. What on earth is ethical or contentious that 14,000 people get done every year, or choose to have done every year in Scotland, and it's then sort of exceptionalised out of the gynecology curriculum, even although it's a gynecology healthcare treatment. So yeah, I think we do need to push to make sure that abortion care is part of the standard medical and nursing curriculum. Could maybe I could ask a question? I don't think we've anything else come in on the questions from the audience, and it partly came to mind, Rachel, when you were saying about the American South. Obviously, things it's changed greatly in Scotland and in the UK over the past couple of years, how abortion care is delivered. And we've already seen some of the benefits from that, in that the gestation that abortions are carried out has gone down significantly. And I think across Scotland, the average is now sitting about that sort of 6-week mark. Do you think the experiences of healthcare providers and people having an abortion in Scotland, and the publications which are now starting to come out from John and the Edinburgh crew and other people in the UK, is that likely to be able to influence greater access to abortion care in parts of the world where people are currently struggling and are currently having more limitations imposed?
I would like to say yes, but I'm not sure that I can say that a lot of the findings and a lot of the evidence from countries in which abortion care can be accessed relatively easily in comparison to say a lot of American states, because for years abortion activists in the US have been looking towards maybe say the Netherlands, in that they have some of the lowest abortion rates, but they have the highest rates in contraception and have very comprehensive sex education. But that doesn't seem to sway any of the anti-abortionists in the US. And I think it is, as Carrie said, stigma is very much about power relationships and suppressing patients' autonomy over their own body. And I don't know about anybody else, but I found it very fun and ironic to see My Body, My Choice be utilized by the anti-COVID vaccination people. So there's signs saying My Body, My Choice at the exact same meeting for outside the Texas legislature, and two totally different perspectives on it. So I think it'll be interesting to see what happens in the next couple of years in the US or in other places where abortion is being actively contested. What happens there. But then we still have the kind of back off movement in Scotland that we're trying to get the Scottish government to widely support buffer zones, rather than just kind of the cop out of saying it's up to local areas and local boards. So, we have maybe our own affairs to get in order as well, unfortunately, as much as it seems comparatively great in comparison to anything, seems great in comparison to Texas, to be fair.
Yeah, I mean, it is interesting, isn't it? They're using the My Body, My Choice when I would say it might be better if some people's placards were Your Body, My Choice, which seems to me what they're actually trying to do. We're just about to wind up this session, but could I just quickly bring John in to ask? Obviously, you've published some initial papers on your work. Has there been much interest or discussion from other places around the work?
In terms of the telemedicine work, well,
yeah.
Particularly in America, one of the good things, and this is not just me showing off, it is just very exciting. The paper that we published from Lothian and also the BPAS MSI paper part of two of the papers that were considered by the federal Food and Drug Administration for the USA. So they have reversed a decision that's been going on for decades around prohibiting the use of mifepristone outside of a clinic setting, which is one of the things that we've had here as well. So there has been some impact from that point of view, that some agencies, and again, it's the complex nature of the American political system in terms of federal and state level provision, and how those restrictions versus actually what you get in terms of healthcare providers and what they're able to do on the ground. But I just kind of wanted to add, in relation to all of that stuff, the problem with the evidence-based approach is that I think that an anti-choice stance is an inherently unevidenced stance to hold. So I think that it's really important for us to build evidence and to supply the evidence to those who are kind of rational and perhaps more neutral or undecided or what have you. But there is this kind of core of people at the heart of the anti-choice movement who will not pay attention to evidence, and we need to think of other strategies and ways to manage them.
Yep. Yeah, thank you. Absolutely, we need to keep pegging away through every possible opportunity. So our time has sadly come to a close. I'm sure all of us on the panel could chat on for hours, but we don't have that luxury. So I'd just like to finish by thanking our audience and thanking very much our panel speakers, Carrie, Nicola, John, Rachel and Jeni, for a really thought-provoking session, which I think all of us have probably learned something and will take something away with us. So thank you all very much. There is a poll for people to give us some feedback on the session, if the audience would like to do that before they log off. Thank you very much.